This video is about aortic dissection. The aorta is made up of three layers: tunica adventitia, which is the outermost layer, tunica media, the middle layer, and tunica intima, which is the innermost layer. And the blood flows through the lumen of the aorta. When there is a tear in the tunica intima of the aorta, the blood flows through this tear and tunnels between the intima and media, separating these two layers. With high pressure of the blood flow, more blood starts to pool inside these two layers and continue to further separate the layers. This increases the outside diameter of the aorta. This is called aortic dissection. The gap where the bloods are pooled is known as false lumen, with contrast to true lumen, which is the regular lumen present inside the aorta. So, what are the risk factors for aortic dissection? The major risk factor is hypertension, which accounts for around 80% of the cases. Other risk factors include atherosclerosis, coarctation of aorta, connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome. These two are genetic causes. They tend to weaken the aortic wall, and this might cause easy tearing off of tunica intima. Injury to vasa vasorum, which are small blood vessels supplying the walls of aorta, can also cause aortic dissection. Aortic dissections can also be iatrogenic. For example, during coronary catheterization and intra-aortic balloon pumping. Similarly, pregnancy is also regarded as one of the risk factors for aortic dissection. But this is slightly more rare than others, and this typically occurs during or after the third trimester and may be related to hemodynamic stresses during perinatal period. Aneurysms can also cause aortic dissection, and incidentally, dissections can also cause aneurysms. If I briefly have to differentiate these two, then aneurysms are dilation of blood vessels that involve the entire thickness of the wall, whereas dissections occur when blood enters the wall of a vessel and separates the various layers. Aortic dissection is classified anatomically into two types, type A and type B. Type A may involve either both the ascending and descending aorta or just the ascending aorta only. And type B is when it involves descending aorta only. Or if we classify it under DiVacchi classification, this is DiVacchi type 1, this is DiVacchi type 2, and this is DiVacchi type 3. Type A dissections, or that which involves ascending aorta, account for 2/3 of cases and have most serious complications, which leads to high number of morbidity and mortality. Now, under clinical features, the classic clinical symptoms of aortic dissection are the sudden onset of excruciating pain, usually beginning in the anterior chest and radiating to the back between the scapula. There may be asymmetry of the brachial, carotid or femoral pulses, often termed as brachiofemoral delay or radioradial delay. The dissection can also rupture into pericardial, pleural or peritoneal cavities. This can cause sudden death due to shock because that's a huge amount of blood escaping the vascular system. Aortic dissection can extend both proximally and distally. Proximally, it can extend up to aortic root and disrupt aortic valve annulus. Or it can occlude other aortic branches like coronary artery, which can lead to MI, or carotid arteries that can cause a stroke, or spinal arteries, which can lead to paraplegia. Or distally, it can compress mesenteric arteries, causing mesenteric infarction, renal arteries causing renal failure, and arteries going to limbs causing limb ischemia. In some instances, the dissecting blood or hematoma can re-enter the true lumen, through a second distal intimal tear, creating a new false vascular channel. This condition is called double-barreled aorta. Now on the investigations, X-ray shows widened aorta. However, CT angiography is more specific and sensitive. Here, in the CT scan, you can see an intimal flap in the descending aorta and a large pleural effusion. Transesophageal echocardiogram is also commonly used. Now, coming to management, type A aortic dissection require emergency surgery to replace the ascending aorta. The surgeon removes the dissected part of the aorta and blocks entry of blood into the wall of aorta. Then the wall is reconstructed with synthetic graft. Type B dissections are treated medically unless there is impending external rupture or vital organ ischemia. Beta blockers or calcium channel blockers can be given as medical treatment to reduce blood pressure. That's all about aortic dissection. Thank you.